Welcome back, everybody. It's great to see you again. And I just want to apologize for the slight delay in starting after the break. I'm going to swiftly hand over to Dame Lesley Regan. It is my honor to welcome Dame Lesley, who is going to speak about women's health and the women's health strategy for England and why this policy and the launch of this policy is important to that work. Dame Lesley, I'm going to hand over to you now. Thank you.
Well, thank you, Esther, and thank you to everybody on the panel, and thank you for being so accommodating. I'm in New York at the moment, and the reason I'm here is because the Commission for the Status of Women is having its 69th meeting, and it is the 30th anniversary this year, 2025, of the Beijing Declaration and the Platform for Action. And I have to say that in my speech later today, I've got to reflect on the fact that although we've gone forward in the last 30 years, we also seem to be stepping backwards as well. And you will understand if I say that some of my American colleagues here are feeling very distressed and concerned, particularly about women's health and their reproductive rights. So as Esther kindly said, I'm the Women's Health Ambassador for England, and I also chair a charity called Wellbeing of Women. And I'm still, a few days a week anyway, working on the front line as a gynecologist and obstetrician. So I'm moving my slides forward, but I'm pressing the green one. Yes, there. So I'm going to start with the obvious comments about how women are 51% of the population, 50% of our workforce, and they undertake more than 2/3 of our unpaid caring roles. And I rather love this Chinese proverb that women hold up half the sky, and I think they really do, probably about 2/3 of it, I reckon, in my book. But I want to share with you this rather busy slide, and I'm going to spend a few moments talking about the data on this, because sometimes when I'm talking about the sad, or rather parlous state of women's health in the UK, people will sort of put up a hand and say, excuse me, which country are you talking about and which year are you talking about? So I'm talking about the health challenges that women in the UK are facing in 2025. And we need to do some myth busting, because it is thought, well, we know that women live longer than men, and then many people assume that that's because they are healthier. But that's not the case. They spend a greater proportion of their later years in poor health and disability. Contraception, which is the single most cost-effective intervention in the whole of healthcare, has become really difficult to access, which I find extraordinary in one of the only countries in the world who has a national health service free at the point of delivery. 45% of all the pregnancies or maternities in the UK at the moment are unplanned. That's 45% of 800,000 maternities. And we know that abortion rates are rising in older women, not young women, women who've completed their families often and tell me that they can't access long-acting reversible contraception. We were in the vanguard for cervical screening and eradicating cervical cancer, which is now an entirely treatable disease with the use of vaccine and screening. But cervical screening uptake is at an all-time low. And I often say to people that I'm talking to, if I was a Black woman and I was pregnant at the moment in the UK, I would be feeling pretty angry, because we know that maternal mortality is significantly higher in Black women and in Asian women, but particularly in Black women. And we've had that information for the last 6 or 7 years, and yet we've not managed to change the figures. Suicide is a leading cause of direct maternal death, and I think that may come as a surprise to some of you, and that although maternal death is relatively uncommon in the UK compared to the global south, of course, every one of them is a tragedy. And if I then go on to say that 1 in 4 of those maternal suicides are teenage girls, I think it really puts to you the state of the inequity and the disadvantage that some women are coping with or trying to cope with. We know that 400,000 women every year will enter the menopause, and their symptoms may last for a considerable length of time. About 1 in 4 of them are going to suffer very severe symptoms. And even if we can't solve the whole thing for women, let's remember that the NHS is the largest employer of people in Europe, and that 1 in 5 of the NHS workforce are menopausal women, and that 80% of that workforce are women. So we've got a real issue there. And even if you talk about period problems and the menopause over your dinner table, I don't expect many women over the age of 60 years in your family or friendship group talk about the fact that 1 in 3 women over 60 will experience some sort of urinary leakage. You don't say, oh dear, I had a leak today. It was so embarrassing, even if you're talking about periods and menopause and other such things. And then we come to the three illnesses, which I think are particularly important for the discussion here, and that is the symptoms of cardiovascular disease, osteoporosis and frailty and dementia, all vary in their presentations for women, and these are the three major killers of women. Although many women think that they're going to die of cancer, that's actually in the minority. Cardiovascular disease varies in its presentation with women, which means that they often receive their diagnosis much later than men. And then, surprise, surprise, the medications and the interventions that they receive, because they've all been trialed in men, don't seem to work quite the same in women. And we've got to change that. Osteoporosis and frailty, major cause of morbidity and mortality. 21% of women will develop osteoporosis compared to 5 to 6% of men. And then dementia, significantly more prevalent in women, and also, interestingly, different presenting symptoms. So if we take Parkinson's disease, for example, women tend to present with a predominant symptom of tremor, whereas men have frailty and stability and gait problems. Now let's move on from that very busy slide and talk about some of the women's health publications that have called for a greater focus on women's health across the life course. And I use this slide simply because I've been involved in quite a lot of them over the last 15 years, and we don't seem to be taking the recommendations on board and running with them. So the first was a publication back in 2011 when I first joined the Royal College of ONG's Council. And this was a study group addressing the need for core women's health services to be maintained in an era of specialisation. And I think we've actually completely ignored that advice. The second is the report that I wrote with Sally Davis, our only ever female chief medical officer. And this was called The Health of the 51% Women. And then in this one, we looked at all the missed opportunities that we have for improving women's health across the life course. And we just ignore or allow them to continue unabated. And then the last was the 2019 report that I authored as I finished my presidency at the RCOG, which we call Better for Women. And the strapline to that was, when we get it better for girls and women, everybody in society has a benefit too. So moving on, this is the life course approach, and I want to emphasize to everybody here that all of these things on this slide are predictable. It's entirely predictable the menstruation is going to be a major issue for women. There is nothing else that happens to a human being more commonly than 12 periods a year for 40 years of their lives. And of course, for most of that time, they're going to need to plan whether they conceive or not. So contraception is another really important point here. Remember as well that most of the women on this call today, if they are mothers, and 1 in 5 of them will not be mothers now in the population, but they're probably only going to be pregnant for 2 or 3 years of their life maximum. And of course, my actuarial lifespan now is about 80 years. And my daughters, my twin daughters who are in their 30s, they're going to be, they have an actuarial lifespan of 100 years. So you can see that this is a really important issue, that we have a lot of years of this life course to be looking after. And historically, we've ignored it. When I came out of medical school, for example, menopause, women just disappeared from view at the menopause at 51 because they were no longer reproductive. So I think that my message here is that we've got to move away from thinking of women as reproductive organs. It's got past the handmaid's tale now. We don't just incubate babies and drop them. We've got a lot of other living and contributing to society to do. So this is the Women's Health Strategy for England, which was the first it was the main recommendation from the Better for Women report, that we must have an NHS-led women's health strategy. It was tricky for the Department of Health and Social Care, I think, to process it all, because they were deluged with responses. Nearly over 100,000 responses to the survey, and then there were another 400 written submissions from organisations and individuals who had expertise in women's health, and some focus groups were also undertaken. And I'm just going to give you a very quick snapshot of something that what I would sometimes people refer to as the horror story of what came out for this call for evidence. And the top 5 topics that respondents wanted to be prioritised were, as you see on the left of this slide. As you will see, some of them are overlapping, but gynecological conditions, menstrual problems, menopause, pregnancy loss, and postnatal support, all really important. And on the right side of the slide, you'll see that less than 10% said that these women said that they had enough information about these topics, and a shocking 84% said that they or the women they were responding on behalf of had not been listened to by healthcare professionals. So the call for evidence was launched in March 2021. The strategy planned for publication later that year, but because of this unexpectedly large response from women's voices and the evidence of the gender health gap and growing disadvantage, it was delayed until the August of 2022. I was appointed as the Women's Health Ambassador, and someone laughingly said to me at the time, well, your job is to implement this strategy, because the strategy was a very aspirational document. It has 8 cross-cutting themes, which you can see here on this slide, and you won't be surprised as a frontline gynecologist and obstetrician that one I've been most exercised by is the access to services. But all of them have got their part to play and have been important, and I'll hopefully come back and tell you a few highlights of what we've managed to achieve a little bit later. These were the 7 priority areas, and to emphasize what I was saying earlier, it was menstrual problems and gynecological disorders that women really felt that had been ignored and dismissed, and they wanted to know more about those and the menopause, mental health and well-being. Cancers were there, but quite a way down the list in terms of priorities, underline my earlier point to you all. And then the health impacts of violence against women and girls, which I think we always underestimate, and which this is one of the topics that worries me most, because I think sometimes it is such a large and enormous topic that everybody's frightened of it and is paralysed and thinks, well, what can I do? But we really do have to do something and tackle it, because it has a massive effect. Now, we've been promoting the concept of women's health hubs to bring together healthcare professionals and existing services to provide care for women in the community. And I'll explain why I think that is so important in a moment. I've been very frustrated for the last couple of decades, where if one of you came to see me in my clinic today, my menstrual disorders clinic at St Mary's Hospital, Paddington, I could fit you with a Mirena device, but whilst I'm doing an examination, which isn't the nicest of examinations, and I'm actually looking at your cervix in order to fit the Mirena device, I'm not really meant to take your cervical smear. And if you tell me whilst we're having this intimate conversation that you think you've got a lump in your breast, I'm not meant to refer you down the corridor to have a mammogram. So I think that you'd all agree with me that you don't mind travelling to a place if you get what you need when you arrive, but going to umpteen different appointments is not on. And so I think the purpose of the women's health hubs, or the concept, is that we need to wrap the services around women, not make them run around the other services. So to implement them, we've been appointing integrated care boards. Were given a sum of money, part of the 25 million for these women's health hubs, which was divided up between the 42 integrated care boards. And by December 2024, we know that 39 of the 42 ICBs had a women's health hub up and running. I want to emphasize that it isn't necessarily one size fits all. There's lots and lots of different models. One of the things I think we've been successful with is establishing a network of women's health champions across every one of the ICSs. And I'm happy to tell you there aren't just 42, there's about 90 of them who come along to a monthly meeting with me virtually and talk about the problems that they've had, the challenges they've faced, and also the successes. So sharing good practice and sharing mistakes as well. We've published lots of resources, and also we've hosted lots of webinars, which all are available and videoed, or filmed, I should say, so that you can look at ways of setting up, or business plans, or clinical guidelines, so that you don't have to start with a blank page. And we're encouraging ICBs to think more and more about this intermediate care. I think there are enormous benefits, and I won't go through them all there, but if we go over to the right side of the slide, undoubtedly this model means improved access, reduced inequalities, enormous health system efficiencies, and we can perhaps talk to that in the question time. But interestingly, two things which I hadn't really factored in at the start, but I'm very impressed with now, and that is the benefit that we achieve there with workforce retention. Because of course it's much more pleasant to work in a system whereby you can say, oh yes, well, of course we can do that, rather than saying, oh no, we can't. And it's also proving to be a very, very useful training resource for clinicians, a whole wide range of healthcare professionals who want to train, for example, in myarena coil or IUS fitting, or putting in implants, or undertaking urogynecology or bladder drill, or rather bladder investigations. These are some of the case studies. I don't have time to go through them all, but I'm very happy to answer them. I want to emphasize that they're not all place-based. Many of them are actually virtual or hub and spoke. So there's no point going to sending someone to have an ultrasound scan and blood test done if they've had an episode, for example, of postmenopausal bleeding, because we know that the gold standard of care is to take an endometrial biopsy. So let's talk to that woman virtually, organize that, arrange for her to go to a health hub that can provide her with a hysteroscopy, a painless one, and also take an endometrial biopsy. And I could ask, go on with many, and many of the women's health hubs are actually involving patient engagement and virtual group consultations, which reach large numbers of people. This is a particularly interesting example of a single point of access. And before the single point of access, and this was at Tower Hamlets in East London, 85% of all the referrals for gynecology went into one of the two hospitals in that patch. And then having triaged them virtually, we then found that we could reduce that number from 85% down to 26% by using the women's health hubs and providing advice and guidance in the community, which is much easier. So impacting, we're really trying to get intermediate care, streamline multiple needs into single appointments, reduce gynecology waiting lists by shifting these services into the hubs. And of course, there are going to be massive longer term savings for the NHS. And I'm sure all of you who know about how one finances or does the healthcare economics knows that really is so important. And that's before we even get to the point of prevention being much less expensive than cure, and reducing pressure. So I would say that this list of 5 things are all things that we should be able to cope with in the women's health hubs in the community, at least in the first instance, rather than sending these women to our NHS hospitals. Of course, collaboration is absolutely key, and you'll see here lots of pictures of me visiting various hubs. Our bottom left-hand side, Rane Thacker, who's the current president of the Royal College, and then Sue Mann, who's recently been appointed as the NHSE National Clinical Director for Women's Health, the first post of its kind. So what progress have we made? Well, I think we have got increased leadership now. As I say, we've got a women's health ambassador. I started in June 22. Sue Mann started in April 24. And we've now got the ICS network of the women's health champions, which has been going now for 18 months or nearly 20 months now. We've got a significantly increased public awareness of women's health, higher expectations of good care, more open conversations, and that, I think, is all helping to reduce stigma, including in the workplace, and significant improvements made to the NHS website. I often say this is not a sexy website to go to, but it is now a lot more informative than it used to be. And even though it doesn't have lots of graphics and things in the actual in the main thing of the website, it's now got a women's health section with over 100 entries, and those are linked to videos and infographics and animations as well. So we've had significant, I think, improvement in access to healthcare via pharmacy services, pharmacy contraception services. And then you may have heard about the baby loss certificates that have been introduced to be eligible for all parents who've had a loss, whatever the gestation, now can get a certificate to receive recognition of their loss. It's not a legal document like a birth certificate, but it does not acknowledge their baby and the name of their baby if they wish to give it. So we've got a lot of other things through the Employment Rights Bill. Large employers are required to publish gender equality action plans. We've got things going through with the Employment Rights Bill, making statutory sick pay payable from day one of sickness, of absence. And this, of course, is going to help many women with gynecological conditions such as endometriosis. We've got an ONS study investigating the impact of endometriosis on the women's labour market outcomes. And of course, through the NIHR research inclusion strategy through the 2022 to 2027, much work is underway to improve representation of women in research, both as participants and as researchers. And as I joined you this morning, I could hear you talking about that. And there's about 700,000 women now from across the country taking part in a world beating or leading trial to test how cutting edge AI tools can be used to identify cases of breast cancer earlier, with significant funding to back that up. Now, I'm just going to finish in a moment. Oh, I can't move it on. Of course, there's been all change. July 2024, we had a new group of political leaders join us, and I just want to pay tribute to Baroness Gillian Merron in the centre there, who has taken on the onerous task of not just maternity, patient safety, mental health, but also women's health as a separate specialty. And she is really championing this with great enthusiasm. The 10-year health plan, setting out the 3 big shifts that we need in moving healthcare from hospital to the community, from analog to digital, from sickness to prevention. And I think we need to add a 4th one there. We need to actually include, we need to move from research and innovation to reality. And that's very much what I'm hoping that we'll be able to achieve with the NIHR help. Just finishing now, someone, as I joined your call, was talking about the economic incentive, and this is a slide from the McKinsey report from last year, 2024. And I very cheekily asked them if they would do a separate analysis for the UK. And if we close the gender health gap by having fewer health problems, fewer early deaths, but most importantly, increasing women's productivity in the workplace and on their caring roles, and expanded participation in the workforce, we could save 36 billion sterling every year. And that, of course, is 20% of the current NHS budget. So I think we have an enormous amount to do about this, and it will be very, very valuable to be able to achieve. And I think we can achieve much of it with these women's health hubs. So I'm going to leave you, because I must stick to time, saying we must implement this women's health strategy with great enthusiasm and determination, because when we get it better for women, we get it better for everyone. And I think we can get it much better for less money, which is also another important thing. And I'll just leave you, as I'm in America at the moment, with a quote from Atul Gawande: better is always possible. It doesn't take genius, it takes diligence and clarity, and it takes ingenuity. But most importantly, it takes a willingness to try. And I think we've got to remember what Einstein's quote was, it is the definition of insanity to carry on doing things the same way and expect there to be a different outcome. So I would say that I really hope that I can work with the NIHR in evaluating the benefits and improvements of these women's health hubs and actually really change the dial for women's health in the UK. And you won't be surprised to hear that I'm now receiving requests to go and talk to many other governments across the world who are interested in doing likewise. So I think the economic argument about women's contributions is really hitting home now. So I'm going to leave it there, and I would be very happy to answer any questions if that's appropriate. Thank you.